request Dr. Haripriya to talk to us on presbyopia correcting intraocular lenses. Dr. Haripriya.
Thank you, sir, for the kind introduction and this opportunity. It's indeed an honor to be talking on this platform. I know that the reach it has had over the recent past. So I'm going to be sharing, as was mentioned, more about the presbyopia correcting IOLs in this part of the session. So as cataract surgeons, I think our primary goal is to have complication-free cataract surgery with a clear cornea post-op day one and a well-centered IOL. Now, all of this is very important, but the question is this enough? So this may not be enough if you look at the patient's functional needs point of view. From the patient's functional visual needs, they have different activities they are involved in, and these could range from different distances, from near to intermediate to distance. It could also range based on the amount of lighting they have. Is it mesopic? Is it photopic? The other concern is, will they be able to do their activities with glasses, without glasses? All of these questions are the ones which make us think when deciding whether we are doing the right thing for a patient when they're having their cataract surgery and IOL implantation. So we are aware that in a young eye, the vision is good at various distances, and this is because of accommodation. So once, when a person accommodates and they look at something at near, the ciliary muscle does contract, so the zonules relax, and the lens becomes a little bit more convex. It's a slight change in the shape of the lens. And because of this, a young person is able to see for distance and for near without the need for any additional correction. Now, there is loss of accommodation with presbyopia, and also after cataract surgery with monofocal lenses. With presbyopia, as we know, the focus, if they are focusing on a distant object, the focus is on the retina and they have a clear image. However, when they look at something closer by, and if they are presbyopic, they are not able to accommodate, so they have a blur image. To have a clarity of this near image, then they will have to use glasses, in which case they can now see well for near, but they can't see well for distance. Now, this is what preempts some patients to opt for multifocal IOLs. So we will not recommend this for patients who have high demand for contrast sensitivity. Some professions, they need to have that very clear crystal contrast, but we don't do it as a routine. So even if you look at aspheric versus spherical lenses, the aspheric lenses were brought in place because that gives a better contrast. And when we, initially when we started using aspheric IOLs, we had like a couple of patients where we did aspheric in one eye and spherical in the other eye, and to assess if the patient could perceive a difference in the two eyes. So this was like a trial which we did. And the patients could not actually perceive any difference in their routine activities. So unless they have that specific need or demand, they may not even perceive this contrast benefit. So we don't do contrast as a routine for multifocal patients pre-op.
And Dr. Haripriya, if I may ask you a practical question, which is, can you tell us about your experience on dealing with the most dissatisfied patient after a multifocal IOL and why it happened?
The individual had a hyperopic classic, and we didn't see that benefit. So an aspheric is because most of the corneas have a spherical aberration and we want to reduce it. Some IOLs have a minus 0.2, some IOLs will have minus 0.27, some will have a neutral aberration lenses. Different companies have different aberrations on their IOLs. So the ideal scenario is to be able to check it pre-op and see how much is the spherical aberration and then try to have it on the IOL, so you take it off. But again, it is not done practically because it's not actually needed because the patient doesn't actually perceive a benefit. But where it can give an additional benefit, it's not a very big cost or difficulty or something. So it's an additional design which now almost all IOLs have. So giving you a little better edge in terms of the contrast is what these IOLs do. There are no demerits per se, unless, like I said, if the patient specifically has a different form, a very high aberration on the cornea, and your aberration on the IOL is going to increase it. That is what is going to make it worse. Like we spoke about the Vivity lens having a high aberration, and then if the patient also has a high aberration on the cornea, this can make it worse. But a regular monofocal aspheric lens does not do much harm. So both in terms of pros or cons, there is nothing much is what I feel.
Haripriya, you talked about monofocal, you talked about lead off, you talked about multifocal. When you did make a mention on the monofocal plus or the enhanced monofocal, and one of our attendees wants to know a few words about the monofocal plus or enhanced monofocal, like the TECNIS eye enhanced results, their indication and results, please.
Yeah. So the advanced monofocal, again, it is basically some wavefront modification on the monofocal IOL. That is what is giving you a little better intermediate vision, which actually is a matter of debate. So when they, when like Eyehance in some papers, it comes under the need-off category. The Eyehance lens, which J&J makes, comes under need-off, whereas some others call it as a advanced or enhanced. All these are the same thing: enhanced monofocal, advanced monofocal, monofocal plus. So it can come under either of these categories. So if you look at the American National Standards Initiative, the ANSI, they are the ones who will define what an EDOF should be. And the EDOF lens should be an IOL which has equivalent vision to a monofocal IOL for distance and better vision for intermediate without increasing your photopic phenomena too much. Now, Eyehance comes into that, but the intermediate vision is not that, it's functional intermediate vision is good. They are, in terms of near vision, they will still need a 1.5 add. Because most of these lenses work on the principle of wavefront modification, which is what some of these aspheric IOLs already have. That is why a Clarion lens or a TECNIS lens, which is not an Eyehance, but just a regular TECNIS, which is an aspheric lens from J&J, these lenses also have some of these functions. Though the company doesn't label them as an enhanced monofocal, they also behave like an enhanced monofocal IOL because the spherical aberration on these lenses gives us a little better functional intermediate vision.
There's a question. In the recent TNOA, there was a talk on press beyond refractive correction before cataract surgery. I think I don't know what he means by pre-beyond or press beyond. In that case, would just implanting a monofocal IOL negate the use of presbyopia glasses?
As the question, the person who's asked the question rightly brought up, there's also a financial part. Now, thankfully in India, we have various Indian manufacturers who have a cost-effective option in all of these categories, be it in the multifocal platform or the advanced monofocal, or be it on the EDOF platform. We have Indian companies as well who make these IOLs, and they bring down the prices significantly. So this enables patients, like a toric, for instance, earlier was only the torics which are made by the multinational companies, but today we have the Indian companies also making them. So which is like, if you're going to give a patient glasses after, when they come for the regular review, we don't want to only take care of the sphere point. We want to take care of the cylinder as well, right? We give them sphere plus cylinder. Similarly, when they have cataract, they have to have a toric if they have significant astigmatism, which we are able to give today because they have an Indian option as well, which is a cost-effective option. But having said that, there may be patients who can't even afford that, right? They may want to still have an SICS, they may want to have it in a CAM setting. There, the best option obviously is to try to change your incision site or the size to take care of the preoperative astigmatism.
So if one eye of a patient was implanted with multifocal, and due to affordability, or I'll add, sometimes if we didn't see it properly or if the patient didn't respond, and if we do implant monofocal in the other eye, will this patient experience diplopia?
No, they will not. And we can do that. If the patient has had multifocal, in fact, I had a patient recently. On the table, I saw that the first eye had a multifocal, and the patient, I was doing the second eye, I just started the surgery. And I was asking the patient, how was the other eye? And he said, eye is fine. I just had my laser. So then I went back to the case sheet to see the patient actually has PDR. Now, this PDR was diagnosed after the first eye surgery. And the second eye also has been advised a multifocal. which I think is not a good idea because PDR patients, the macular status may not be good. So on table, I spoke to the patient and converted from a multifocal to a monofocal. The only thing is the patient should realize that with the monofocal, that eye, their near vision may not be great. So both eyes together, they can probably have some amount of near vision, but it won't be like, having binocular clear near vision. The reverse is also true. If the first eye has a monofocal and the patient is highly motivated for a multifocal in the second eye, that can also be done if the patient understands the pros and cons of both these lenses.
And a final question, any extra precautions required while unloading the multifocal IOL during surgery?
Not really. So I think it is basically your delivery system which the company has to give. The only thing is if you have any issue with the lens, it's always better to have a backup IOL in case your IOL breaks or there's an issue with the cartridge or the IOL slips. On table, you don't want to be at a loss, right? Usually the monofocal, normally we have an inventory. It's easy to pick up another IOL. Multifocal, we may not have the inventory. So when you order an IOL with the company, we like to always have a backup lens as well, just in case for that rare event, you have another option. But otherwise, we won't find, it'll be similar to what it is on the monofocal platform.
Thank you very much, Dr. Haripriya, for this exhaustive lecture. And for all the students, I would once again, this is the advantage of archiving it in your DigiNow.